So there's many reasons why it would be advantageous for patients to have decreased exposure to vancomycin. So I talked a little bit about how all this data is derived from troughs, and we realized that with all this trough data, we're actually overexposing patients, and vancomycin nephrotoxicity is such in that it's exposure related. So we see an increased rate of nephrotoxicity that is directly correlated and related to the amount of exposure that the patient receives. So by decreasing the amount that we administer, we also hope and we find that the rate of nephrotoxicity also decreases, and that's been shown in the literature for other institutions that have actually rolled out AUC dosing, as well as when we even look at the original trough literature. Even when we go back to the 2009 ASHP vancomycin dosing guidelines, we do find independent associations with nephrotoxicity when the trough is over 15 micrograms per milliliter. Different ranges, but it's not like a hard, it's more of a continuum, but the range is typically 15 micrograms. Above 15 has been associated with acute kidney injury in these patients. So that's the main reason to go back to AUC dosing. But there's also other reasons as well. It gets patients on a stable regimen sooner. So if you collect a peak and a trough after the very first dose in the patient's regimen, we're able to achieve a more stable regimen for the patient sooner, and it results in less levels that we actually take on these patients long term in their treatment course. So many different reasons why we should switch.